It is a great pleasure to introduce my colleague Mike Ackerman, who's the Wendland Rice Smith Chair of our Sudden Cardiac Death Clinic. He is a thought leader in the area of channelopathies and sudden death syndromes. He has written the guidelines and served on the committees that really inform what all of us do in this space. So it's a great pleasure to have him speaking with us now. Mike, thank you.
Thanks a lot. Good afternoon, and thanks so much for letting me be part of this board review course. And I want to congratulate you on completing the first half of the board review course. I'm the kickoff for the official second half of your course, and so hopefully we will kick it off well. It's kind of challenging when this is your postprandial experience, but let's start with this as your first question before the talk begins. You observed this pedigree, you took it during your history, and you notice that the father is mutation positive and 3 of his 4 children are as well. What's the inheritance pattern? All right. And then you are encountering a patient with this ECG. And the most commonly identified genotype for this syndrome involves which of the following? And 3/4 of you are thinking of the syndrome reflected by this ECG as Brugada syndrome, stemming from loss of function in sodium channel defects, and you guys are in really good shape already. I'll see if I can enhance on this. I'm conflicted. These are the obligatory RWIs to disclose. I don't think they'll affect my ability to convey this material in an effective way, especially to achieve these these objectives together. We will dance through the 3 major channelopathies, because those will be on the boards, the others will not in all likelihood, and discuss their clinical presentation, diagnosis, and treatment, and then help you have a management approach to a patient with one of these identified channelopathies that makes sense in practice and will be correct for the boards. The discipline of the cardiac channelopathies is an expanding one, and it's an incredibly exciting one. It was birthed 20 years ago with the understanding of long QT syndrome as a channelopathic condition, but it's not alone. In fact, there are now many different channelopathies for which programs have a dedicated genetic heart rhythm clinic or a channelopathy clinic. We won't go through the trivial ones as channelopathies, but we will go through the big 3, starting from least prevalent to the most prevalent. So we'll go through Brugada syndrome, then we'll turn our attention to CPVT, and we'll conclude for the most of our time together with long QT syndrome, because it is the most understood and it is the most tested and testable of the channelopathies. So Brugada syndrome is the syndrome of abnormal right-sided ST segment elevation. Pathophysiologically, it's the syndrome of abnormal depolarization, repolarization, repolarization, depolarization, depending on which camp you're in, of abnormal right ventricular outflow tract cells, particularly those located in the epicardium. So Brugada syndrome is this ECG and this phenotype of syncope that you and I don't like, nocturnal agonal respirations that the patient's next door neighbor, the bed neighbor, doesn't like, and often more expressive in the men over the women. There's a strong gender predominance of males over females. Average age is 40 years. Here is what you need to know for boards and for practice. This ECG, the ECG that's called the type 1 Brugada ECG pattern, 2 millimeters or greater elevation in any of the right-sided leads, V1, V2, V3. Just one is sufficient by guidelines now, of this cove-type pattern as shown here. What you are disinterested in is the non-specific type 2 saddleback or even less specific type 3 pattern, unless it converts to the type 1 pattern with either maneuvers, high lead ECG placement, electrode placement, or with drug provocation. So the high lead positioning is the simple triplicate ECG, where you start with a standard ECG with the right leads in their standard position, and then you move V1, V2, 3 up one intercostal space and repeat, and then you move it again up towards the head and another intercostal space and repeat it again. And if it converts to the type 1 pattern, then that is diagnostic of the type 1 Brugada ECG pattern, because all the high lead maneuver is doing is trying to anatomically locate where the right ventricular outflow tract is arising from. So here's the diagnosis. You have this ECG, the type 1 pattern, and your patient fainted in a way that you did not like. The whole world agreed that that's Brugada syndrome, and that will always be the correct answer for the boards. The world also agrees that if your patient and another one of his or her relative exhibits the type 1 Brugada ECG pattern, that's Brugada syndrome. Asymptomatic, perhaps, incidentally detected, but that's Brugada syndrome. That's not just familial type 1 Brugada pattern. Everybody agrees. Everybody agrees that if your patient exhibits this ECG and has a positive genetic test for a Brugada syndrome susceptibility mutation, that's Brugada syndrome. But now what has messed with your lives and my life is the new guidelines from 2013, which says one ECG that shows the pattern at rest or with high lead maneuver or with drug conversion from non-diagnostic to diagnostic, not only is the Brugada type 1 pattern, but that is Brugada syndrome. It's given a new practice for me. It's called disqualified pilots at their FAA physicals. So this is going to get addressed and readdressed and refined, but right now this is the guideline definition of Brugada syndrome, the self-sufficiency of an ECG that evidences the type 1 pattern, 2 millimeter elevation in the right leads, any of those 3 leads, at any point in time with any lead placement in the presence or absence of a Brugada precipitating medication. Now, at the heart of Brugada syndrome are defective ion channels for the most part, or ion channel auxiliary subunits, but for the board, what matters is the sodium channel. 75% of you knew that already, where we think of Brugada syndrome as a sodium channel loss of function disease. And that's a correct statement 20 to 30% of the time. We now have many Brugada susceptibility genes, 20 and counting. These do not matter, except perhaps maybe the calcium channel or calcium channel mediated Brugada syndrome. So for boards and really for your practice, you can forget 18 of the Brugada genes and just know 2 of them. Sodium channel mediated Brugada syndrome, it is the most common genotype, but it is only a fourth of this disease. In other words, most of Brugada syndrome is genetically elusive in 2015. A little nugget is if your patient has the type 1 Brugada pattern and a prolonged PR interval, then the likelihood of sodium channel mediated Brugada increases a lot to 40%. And if they don't show PR prolongation, the yield of the genetic test is sub 10%. And if you have a patient who has the Brugada pattern and a short QT interval, then you wonder about the possibility of calcium channel mediated Brugada syndrome. Who gets the defibrillator? Everybody agrees, aborted cardiac arrest, class 1 indication. Most agree, syncope and this ECG, or at least syncope that you and I don't like, a rhythmic sounding syncope you get in ICD. And then the world still disagrees on this. What do we do for the incidentally discovered asymptomatic person who we're now calling Brugada syndrome, and we're now calling more of them Brugada syndrome because all they need is one ECG in any lead with any drug? We talked about that conundrum, didn't we? Now the data would actually suggest that perhaps we don't even need to be doing an EP study, and that we need to be concerned about the possibility of false negatives with a negative EP study. Nevertheless, the current guidelines as of a year and a half ago state that an EP study is a 2B indication, which is kind of misleading. Well, actually what it states is that the ICD is a 2B indication in the setting of a positive EP study. What it really should say is that the EP study is a 2B indication. You and I could or could not choose to do it, because if we choose to do it and we induce VF, it hardly is 2B in any of our minds any longer, right? So it almost automatically becomes a class 1 if we induce VF. But that won't be on the boards, it's too controversial. For the boards, though, if there is a role of pharmacology in Brugada syndrome, it is one drug currently, and that is quinidine. Quinidine is offered for the asymptomatic host, and it is offered in some countries for the patient who has a positive EP study. It certainly is offered in the United States for the person who is having recurrent Brugada events, recurrent ICD shocks, and as a way to minimize the likelihood of a future event, quinidine. Why quinidine? Not by virtue of its sodium channel blocking activity. It really is by virtue of its ITO blocking activity, and you might hear some of that pharmacology in an upcoming lecture. I doubt it will be on the boards, but for refractory patients, the offer is RVOT epicardial ablation, which starts to make sense when we understand that we really think we're dealing with a disease of the RV outflow tract epicardium. And so epicardial ablation is a treatment option. For all Brugada patients, Brugada and fever is not a good combination, so we counsel about quick fever reduction, and in some settings, we even advise the children in the setting of a first fever to present to the ER to get an electrocardiogram to see if they've converted into a positive type 1 Brugada pattern. There's a few drugs that are important for you and I to know about, and those are on brugadadrugs.org. Probably the most important are some of the spinal anesthetics that are used for elective orthopedic surgeries. I suspect every campus that's represented by you all have that unexplained sudden death during an elective hip surgery, knee surgery, and what it could be is the spinal anesthetic bringing out and precipitating Brugada syndrome in an otherwise concealed Brugada host. That's Brugada for the boards. Now, CPVT for the boards is the syndrome of abnormal diastolic calcium overload due to leaky ryanodine receptors. This is the hallmark ECG on stress testing, and the mimickers of this ECG could be digoxin toxicity or genetic catecholaminergic polymorphic ventricular tachycardia. It presents with exercise-triggered events, fainting, seizures, ceasing. The heart is structurally normal on imaging. It's the kind of story where you've learned to think, this really feels like long QT syndrome, but where's the beef? Where's the QT prolongation? When there is none, think CPVT. Order the most important test, which is stress testing, but don't wait for the board's answer. This is the board's answer, bidirectional ventricular tachycardia, but you'll be waiting a long time if you're waiting for this. I take care of a lot of patients with CPVT, and I can count on one hand the number who have done this on stress testing. Instead, mount your suspicion, let it grow if you put them on the stress test and they have completely normal rhythm at rest, and then it starts. And the it that starts is at about a heart rate of 120, 130. Ectopy emerges, usually simple PVCs initially, with increased heart rate and increased workloads, PVCs in bigeminy, and that might be all you'll get. Sometimes you'll get couplets. You might even receive one bidirectional couplet. And then as soon as the patient goes into the recovery phase, completely normal. Think CPVT in that setting. Order CPVT genetic testing to see if you can confirm the disease of abnormal calcium-induced calcium release due to defects in the ryanodine receptor. There are now 3 CPVT genes if you count all 3 of them. The most important one for the boards and for practice is the ryanodine receptor, and it accounts for about 2/3 of all CPVT. Perturbations in the ryanodine receptor that make it leaky, causing increase in diastolic calcium, is the substrate for the delayed after depolarizations of CPVT-triggered arrhythmias. Now here we used to be very aggressive in terms of ICD aggressive in a patient that you and I diagnosed with CPVT. Aborted cardiac arrest, got a defibrillator. I don't like beta blockers, got a defibrillator. I just fainted on my Nadolol, got a defibrillator. I don't wait for another event, so a symptomatic presentation, bought the patient a defibrillator. Or your test came back positive, you get a defibrillator anyway. That has all changed, where right now the only clear indication of an ICD is aborted cardiac arrest. And this is because there have been increased examples where the defibrillator itself has been the cause of the CPVT patient's death. With the first shock, say for example an incorrect shock for sinus tachycardia that then woke up the dragon, and it beget the spiral, the death spiral of shock after shock, to try to terminate the awoken CPVT substrate. So now we try very hard to never implant a defibrillator, and only as the last resort in the management of patients with CPVT. Instead, beta blocker therapy is the mainstay, and it's Nadolol and propranolol that are the preferred beta blockers based on experience, not randomized data. And then additional combination therapy with beta blockers and flecainide, a great story, don't have time to talk about it, that has emerged with the use of flecainide, not as a 1C drug, but by its properties as a ryanodine receptor stabilizer, if you will. And then the role of denervation surgery or left cardiac sympathetic denervation. So the combination drug therapy approaches, beta blocker alone, or beta blocker in combination with flecainide, or denervation alone, or denervation in combination with drugs, is now the treatment of choice for symptomatic CPVT that is less than death attempt. So syncope or seizures. Breakthrough events now prompt us to go to combination therapy rather than going to an ICD. So be slow to go to the ICD in CPVT. Now we'll spend the balance of our time, 20 minutes and counting, on the most common of the cardiac channelopathies, that of long QT syndrome. About 1 in 2,000 individuals have this. It is over 50 years old, almost 60 years old now since its clinical description. The birth of the discipline of the channelopathies now is just 20 years old following Mark Keating's discoveries. That discovery ushered in the decade of research-based genetic testing, which gave way for the past 10 years to clinically available genetic testing for long QT syndrome and the other channelopathies that we spoke about. We've had a changing landscape in terms of the reimbursement landscape among third-party payers, but that doesn't matter for the boards. You and I have had the first set of guidelines as to how do we utilize genetic testing for the patient that you and I suspect to have a channelopathy like Brugada or CPVT or long QT just now for the past 4 years. And the latest guidelines that we will be referring to in part is a 1.5 years old in terms of the diagnosis and treatment recommendations for a patient. Long QT syndrome, the most common. 1 in 2,000 individuals have long QT syndrome, and that may be an underestimate now. It may or may not show QT prolongation, and we'll talk about that. The patients may or may not ever have a torsadogenic experience of fainting, seizing, or ceasing, and we'll talk about the likelihood of staying asymptomatic or experiencing a sentinel event. Everything hinges on the story when it comes to all of these channelopathy evaluations. In other words, you and I need to decide when we hear that our patient spelled whether we thought that was a normal sinus rhythm faint, normal sinus rhythm seizure, or whether or not that was a fainting that was precipitated by torsades or an arrhythmia, as illustrated here. So it's up to us to elicit the features of concerning fainting versus reassurance, who cares, no big deal fainting, because we have to keep in mind that all of our channelopathy patients have the right to have boring vasovagal syncope. So they can have that, and how aggressive we proceed with the diagnosis depends on whether we felt that we could blow off the blackout or whether we needed to snap to. Fainting can spell trouble. And when it comes to long QT syndrome, the strongest predictor of a future faint, not only a future faint, but a future funeral, is a faint that you and I did not like. So if you and I assess the faint to have been arrhythmic in origin for that patient that we are contemplating the presence of long QT syndrome, that carries the highest hazards ratio for a future event, far higher than what kind of mutation the patient owns or how long the patient's QT interval is. So these kind of faints are the penalty box faints, faintings in the setting of exertion, not after exertion. During, mid-stride, sliding into second base, going up for the layup, striking the soccer ball, that kind of faint. Auditory triggered faint, or fainting during the postpartum period, or exertion triggered seizures. We all need to work with our neurologists to convince them that exertion triggered generalized seizures might be starting from the organ south of the brain. And we have so many misdiagnoses of long QT patients initially diagnosed as epileptics, treated with anti-epileptic medications, and we were treating the wrong organ. So if there's a story that we don't like, then we proceed to the most important first test. In CPVT, that most important first test is the stress test. In long QT syndrome, the most important first test is the 12-lead ECG. And here, together, we all have made a fair bit of fumbles on our ECG interpretation as to the significance or the lack of significance of a prolonged QT interval, a borderline QT interval, a maybe prolonged QT interval, and we'll see if we can help with that. Sammy Viskin reminded us a decade ago of the sobering reality, at least then, hopefully it's not as bad now, that we, the community of cardiologists, are not so hot at measuring the QT interval. And so the goal in the next few minutes is to make us better than the 1/3 of heart rhythm specialists or the 3/4 of cardiologists who can't recognize a long QT interval. And it really will be rather straightforward. Your friend is lead 2 or V5. You should put your eye or your calipers on the QT interval, and if your QT interval is matching the computer's, you can trust that the computer knows how to do Bazetts, knows how to do math. But if your QT that you're deriving is not matching the computer's, you need to ask yourself why. And we need to go back to the basics and say, where have we determined has been the end of the T wave? And so we need to do the teach the tangent or the avoid the tail and put the eye or the caliper on the downslope of the T wave and censor the end of the T wave there. Resist the urge to take it there. If you take it out at the end there, you and I will commit the sin of QT inflation secondary to U wave inclusion. And that is the number one reason for overdiagnosed long QT syndrome presenting to Mayo's long QT clinic. So we'll have to decide about the length of repolarization. Does this length bother us? But then we also need to decide, more importantly, about the look of repolarization. Peter Schwartz once said, I don't measure the QT interval, I look at it. And so there's the length of repolarization that we have to decide. Are we bothered by the length? And then there's the look of repolarization. And this is Board's rich material right here. They love to ask this about the patterns, the T-wave morphology patterns, and the underlying genotype, with broad-based being LQT1, hump-bumped, notched being LQT2, and a normal T-wave inscribed after a long isoelectric segment being LQT3. So with that quick primer, what do you think? Here's the ECG, and you would answer for the boards with that ECG that this is which of the genotypes? Great. So just immediate recall, 2/3 of us got it right as LQT3. So always the correct answer for the boards, but this patient didn't read that. So for practice, don't be bothered if there's a mismatch between the board's predictions of genotype and what our patient actually possesses. But this is the LQT3 looking ECG, and for sure it will be asked. Now, you see this ECG. Is this a normal ECG or concealed long QT syndrome? The QTC is 415. You're deciding whether that number bothers you. But on an ECG reading diagnosis, is this ECG normal or abnormal? Great. So the tiramisu didn't do anything nasty to anybody in the room. This is as normal of an ECG as it comes. And yet, this patient absolutely has long QT syndrome. Now, it's different when you have as a portal of entry that this is family screening of an established case. But the point is very important, and that is we can never tell a family with established long QT, established CPVT, established Brugada, that you do not have the disease because your ECG was normal. And that's why for all of these conditions, it's a class 1 recommendation to do mutation-specific genetic testing of the appropriate relatives, because there's no ECG that's normal enough to rule out the condition in that setting. Now, of course, on a high school screening program, this is forever and always a completely normal ECG. So again, mutation-specific genetic testing as a class 1 indication once the mutation has been found. Now, you think a QTC greater than which of these thresholds is too long? What number is actionable in your own practice? Let's go ahead and vote on this. And we almost get a beautiful Gaussian bell-shaped distribution, which is lovely, isn't it? Our patients, depending on which side of the room they walked into, are either diagnosed as prolonged QTC, possible long QT syndrome, you're done with sports, oh, might as well throw in an ICD, or peace be with you, nothing wrong. And this is really important for our practices to have a frame of reference as to this metric of cardiac repolarization, the surface assessment of our patients' myocyte action potential durations as reflected by the corrected QT interval. We have a shift between healthy women and healthy men. Women are shifted slightly to the right. Of course, patients with long QT syndrome are more right shifted to where the average QTC in our long QT clinic is 482 milliseconds. That's an interesting number because that's about the 99.5th percentile value in healthy women. Not much of a challenge out here in terms of something abnormal is going on. Now, it might not be long QT syndrome. It might be drug-induced QT reactivity, but it is abnormal. Now, here's numbers that you need to remember. 600 used to be the line of high risk, but hardly anybody has that. Then it was moved to 550. The one line in the sand that you must remember is 500 milliseconds. No matter why our patient crosses 500 milliseconds, with a couple of exceptions, amiodarone, who cares? They all do. Bundle branch block or wide QRS, they all cross 500. But if you have normal sinus rhythm, normal QRS, not on amiodarone, and our patient is above 500, they are in proarrhythmic territory, whether it's due to hypokalemia or whether it was due to diabetes, coronary artery disease, or a genetic mutation. They've entered into a proarrhythmic window. Remember the 500 line. Now, from a diagnostic standpoint, we have this dilemma, is the overlapping of patients who have the mutation but don't have QT expressivity at rest. Normal QT interval long QT syndrome or concealed long QT syndrome. And this is our indoor record for how concealed can you be, and yet you have the mutation. That's again why we cannot give any reassurance to the family members based upon a normal ECG. Now, juxtaposed to that is we've had these screening recommendations. The 440 line, oh great. What word gets ascribed to the 440 line? Borderline QT prolongation, which all too often and prematurely gets translated from borderline QT prolongation to possible long QT syndrome. And that's a dangerous transition for our patients because that transition is almost never true. And so we have the borderline or this overlap zone that is causing a lot of overdiagnosis of the syndrome. And now we have borderline dropped and replaced by guideline sanctioned definition of prolonged QTC. So for boards, the guideline definition of a prolonged QTC is 450 or greater for men, 460 or greater for women. And yet, just because you satisfy a guideline-based definition of ECG QT prolongation, that will equal long QT syndrome less than 1% of the time. So don't be quick to call somebody long QT syndrome just because they satisfy the correct board's answer for what constitutes an ECG definition of a prolonged QTC. Now, at the heart of long QT syndrome, or at the heart of 2/3 of all long QT syndrome, and you must know this, are loss of function mutations of voltage-gated potassium channels. That's the root cause for 2/3, almost 3/4 of this disease, is loss of function to one of two voltage-gated potassium channels. Now, those two channels are not alone. We're now up to 17 long QT genes, but who cares? You don't have to because you only need to care about the big three. The big three that are responsible for LQT1, LQT2, and LQT3 is rich fodder for the board's portion of the channelopathies. So before we review those, I just want to give you a summary of the yield of genetic testing. When you definitely have a patient with Brugada syndrome, it's about 25 to 40%. When you're really sure about CPVT, it's around 2/3 genetic test positivity. When you're really sure about long QT, it's 75% positivity. And that's because of that, the guidelines have said the following, that it's not a one-size-fits-all in terms of finding the mutation. It depends on the disease. We haven't even talked about short QT syndrome. It won't be on the boards, and the genetic contribution is rather trivial. On the other hand, long QT syndrome is the genetic channelopathy and cardiomyopathy where the impact across the triad of diagnostic, prognostic, and therapeutic is most greatly felt. Now let's go through the big three genotype-phenotype correlations that will be addressed. Again, the significance of the genetic test is strong such that where if you and I suspect the disease long QT syndrome, we should pursue genetic testing to find out which flavor of long QT syndrome our patient has. We'll review the three main flavors. LQT1 is the most common. About 1/3 of all of our families have it. This is a loss of function mutation to the IKS potassium channel. The next most common is LQT2. It too is a loss of function to a different voltage-gated potassium channel of phase 3, the IKR potassium channel. And important with this channel is the bullseye for virtually every drug that prolongs the QT interval as an unwanted side effect of the medication, does so by pharmacologically blocking the IKR potassium channel. So genetic loss is LQT2. Pharmacologic inhibition of IKR, erythromycin, sotalol, dofetilide, Haldol, you name it, a lot of drugs, it's through IKR block. And the third major type is LQT3, which is due to, if you will, leaky sodium channels. So most long QT syndrome is a voltage-gated potassium channel disorder, and 5 to 10% is a sodium channel problem, sort of the opposite of the sodium channel mediated Brugada problem. We have minor types, and if we're not going to talk about the minor types that our lab discovered, we're not going to talk about these either, because they don't matter. What matters now are these next 3 slides. The gene-suggestive ECG patterns. Remember, broad-based, type 1. Humped, bumped, notched, type 2. Normal-looking T wave after a long isoelectric segment, think type 3. So the ECG pattern recognition. Second, and this is labeled wrong in your syllabus, it should say gene-specific triggers. Remember here, exertion, activity, swimming as the trigger of their faint, think type 1. Auditory signaling, so phone ringing, I faint and collapse and die, think type 2. The postpartum period for women, think type 2. Non-activity is the setting more likely for type 3. And finally, the third most important, or clinically perhaps the most important genotype-phenotype relationship is this is the disease, the only disease in genetic cardiology of the channelopathies and cardiomyopathies where our treatment strategy hinges on the knowledge of the genotype. And this is because there is gene-specific responses to beta blocker therapy, where beta blockers work great in LQT1, quite good in LQT2, and they are effective in LQT3, but nowhere to the degree that they are in LQT1. So remember those 3 genotype-phenotype relationships, and now we'll conclude with a few comments on our treatment options. Most of long QT syndrome patients do not need this. Long QT syndrome is not an ICD disease. The vast majority of patients with long QT syndrome do not need and should not receive an ICD. Instead, this is mostly a pharmacologic disease where our approach is mostly beta blockers. But for those who need an ICD, the secondary prevention indications are clear. Death attempt, class 1 ICD. I don't like my beta blocker, or I just fainted on my beta blocker, a class 2 indication to an ICD, and I would actually argue that we have a better option than the device, and that would be left cardiac sympathetic denervation. I doubt you'll be asked about predicting the future because the guidelines were silent on when would we go maximally aggressive with a prophylactic ICD in an asymptomatic host. The guidelines were silent, but I won't be. This is where we think of it. If the QTC is really long and you're not LQT1, it would be reasonable to be more aggressive. We don't wait for you to be as long if you are an LQT2 woman. Infants have a high-risk version when they present with 2-to-1 block. When the long QT is accompanied by deafness, that's a high-risk version. But importantly, I think for your practice and for boards, is the next to last should not be on there. In other words, family history is not a personal risk factor. It's an emotional risk factor, but it's not an evidence-based risk factor, unlike what you'll hear later, where family history is one of the big risk factors in hypertrophic cardiomyopathy. It is not in long QT syndrome. So they should not get an ICD for the death of the aunt. And LQT3 should not be triggering a reflex to the ICD like it has in the past. Instead, we're mostly dealing with beta blockers. And again, I don't think they would be asked superiority of one versus the other for the boards because there's a debate. The largest long QT centers in the country and in the world use the non-selective beta blockers of Nadolol and Propranolol and have a strong dislike for Atenolol. There is no randomized study to prove that superiority, and there never will be. Now, just a quick comment about denervation and its role. So juxtaposed between device therapy on the right, drug therapy on the left, is left cardiac sympathetic denervation, which for long QT syndrome and CPVT has well demonstrated antifibrillatory properties. And it is not curative, but it can make the likelihood of another long QT triggered episode or another CPVT triggered episode much less likely. And reasonable indications are an appropriate ICD shock. We should be thinking about providing denervation protection. I don't like beta blocker, I just fainted on my beta blocker, we should be thinking about denervation therapy rather than going to device therapy. The young, where they are assessed to be at high risk, but you and I are concerned about ICD-related comorbidities, it seems to be a good bridge, and perhaps those in developing countries. So with that, we've completed our sojourn through the big three of the channelopathies. Let's see how we did together with some of the relevant boards type questions that I think are high likelihood for the boards. And with that, I want to thank you for your attention, and we'll have Dr. Amon and I go through some of these questions together. Thanks a lot.
Thanks, Mike. I'll point out that Mike has a couple of additional lectures that are on the portal. One about the 101 of genetics that you need to know, and one about more details about the human action potential. So if you're interested in those things or need a primer on those, they're in the online content on the portal. So let's click forward here and see. All right, so let's spend a little bit of time on this diagram. So you've got this pedigree, and you can see at the bottom that 3 of 4 children of this diagnosed 42-year-old male in the middle are also gene positive. So there's the proband, and age 8 girl, age 10 boy, and age 5 boy are also gene positive. So what do we know about the genetics? Is it X-linked? Is it autosomal dominant? Is it sporadic? Is it autosomal recessive? Good.
Great. That was even better than at the beginning. And just to bring you back to this, where did it start? So here from this, you would say it was sporadic. But for the boards, the correct answer is always, when it has to do with a pedigree, for virtually any heart disease that has a genetic component, will be autosomal dominant. So this is sporadic de novo in terms of its origination, and assuming one minor caveat. Anybody want to suggest that one? That grandpa's grandpa. But, okay.
Misattributed paternity, they call that.
Yes.
So can I just ask you, again, this kind of goes over into the genetics talk a little bit, but if you could give them 2 or 3 things that you think they just have to know about genetics before we focus more on the arrhythmias?
So I think the number one thing is always answer autosomal dominant. The other thing would be to start to have an understanding, and we'll have a question that addresses this coming up, between variable expressivity and penetrance. These are hard to get at on a boards question. Clinically, they're incredibly important for us to have a grasp on, and that is, say, for example, long QT syndrome. The variable expressivity is, let's say everyone in the family showcases the hallmark abnormality, QT prolongation, no doubt about it. Well, they may not all be experiencing the same storyline. They could be asymptomatic. One could have had death as infant. One could have had in utero death. Another one could have had seizures at age 25. One could have had a postpartum event. So that's the variability expressivity, meaning they're showing the objective feature of the disease, but the sequelae is different. That's expressivity. The other is penetrance, and this is important in our field of diseases because unlike, say, Huntington's disease, where if you inherit that neurologic mutation, you will show the consequences of that disease at said age. Well, that's not true of our diseases at all, where ownership of the mutation may not result in expression of the disease at all. And that's important. That goes into our counseling for a patient with HCM. Just because they inherited the mutation, they may or may not ever manifest abnormal hypertrophy. They may or may not ever manifest QT prolongation. So I would say those are the 3 key concepts.
Good. All right, next question. You got big, thick arrows pointing at stuff on some ECGs. And so most commonly identified genotype for this syndrome involves gain of function calcium, loss of function sodium, defective sodium, calcium, and potassium channel beta subunits, or loss of function potassium channel defects. They all sound bad to me.
Not good to have.
Yeah.
No. But we went from 61%, I think, no, I think you were already at 75% to almost perfect. So you're absolutely right. Brugada syndrome, loss of function sodium channel, but in our own practices, remember to keep in mind that that's a true statement only 25% of the time. Okay? Most of Brugada syndrome continues to be genetically elusive. Great job. We'll stick with this syndrome.
Yep, all right. Pharmacologic agents and maneuvers used to treat this syndrome include quinidine, adjmalene, procainamide, or hyperthermia.
Fantastic. All the others are provocative maneuvers to try to confirm or bring out or unmask. And the hyperthermia is what we counsel them to avoid, particularly in the setting of fever. Great job. Here we'll stay one more on this disease.
This is a 40-year-old male with a history of fainting, and this spontaneous ECG, the first-line therapy is quinidine, pacemaker, ICD, or beta blocker.
I even saw that, so I'm not going to say you were brilliant if you ace this one, but you are.
So.
Oh! Somebody wasn't using the help provided.
Yeah.
So this is an interesting one in the sense that, again, it really hinges on, did we like or not like the faint?
Right.
If we did not like the faint, then it's a straight line to an ICG. If you and I said this really feels like a vasovagal episode, which I think we're hearing about shortly,
Yep.
then you stand down and you still have an asymptomatic Brugada patient who happened to have an ordinary faint. And so the assessment of the faint is what drives this to an ICD or nothing, but since nothing was not an option, ICD is the way to go. Okay.
So this ECG tracing is most indicative of which of the following: increased IK1 current, tight ryanodine receptors, DIG toxicity, or decreased sodium current.
Good. So this ECG, and a little tricky, right? Because some of you thought there's two correct answers here. This ECG is either digoxin toxicity or CPVT. But the root cause of CPVT is leaky ryanodine receptors, where the genetic insult in the ryanodine receptor made those receptors leaky, if you will.
So can we go back to that? Just
Yeah.
someone asked a question that's practical. So let's say you have someone on the treadmill and they go into CPVT.
Yeah.
What's the drug you give to get them out of it?
Well, the drug at that point, if they just do this, it may be get them off the stress test.
Yep.
Yeah.
So you're not going to prop them up and make them run, okay?
Yes, so we get them off the stress test. If they're staying in it, then it may not be drugs at all. It may be electricity.
Electricity.
But then the IV drug that you may need to get this under control if we create a storm actually turns out to be lidocaine. Now, we don't have rapid access to IV flecainide, which would be the pharmacologic drug that you'd want to do. The other thing that you want to do is you want to get everybody in the room as relaxed as possible in a hurry, because one of the best antiarrhythmic...
No excess catecholamines.
Turns out one of the best antiarrhythmic drugs for long QT patients and CPVT, and you can just put this one in the back pocket for you, is Ativan and Valium. The number of patients that I've had with long QT storms where we call them up and say, is the patient on Valium or Ativan yet? They said, no. They said, why? Well, it's a great antiarrhythmic, trust me. It's a great antiarrhythmic to short circuit the catecholamine link.
And everyone just feels better anyway.
Yeah. A couple here on this, the syndrome reflected by this ECG.
The patient has this disease and is pregnant. What is the likelihood that her fetus will be affected by the disease?
Now, Dr. Amon helped you out a little
Yeah.
bit.
You said always answer autosomal dominant. I think you said that, right?
Now here, I did.
Okay.
But here, even in the back room, they put the answer incorrect because the operative word here is affected. So it is not 50-50%, it's actually uncertain. Because the correct answer is it depends.
So inherited is 50-50.
Inherited. In fact, let's see if we can get 100% now if you ask the question this way.
Oh, gosh, I'm setting you up.
Yeah. So what is the likelihood that our fetus will inherit the disease susceptibility mutation?
What this question demonstrates is that you always must read the question carefully. The last two questions together. Yeah.
Great. So autosomal dominant follows the 50% transmission to progeny rule. Now, if I own it, doesn't mean I'll show it. That's affected. So the 50-50 thing, that will be asked on the board. This business about will I be affected or not, that won't be, but that is probably the most important thing for us to remember in our practice when it comes to counseling the families with one of these autosomal dominant conditions. Just a couple more. Oh, you'll get this one. I think this is going to be 90%.
90%?
I'm thinking.
Okay. Congenital long QT syndrome is most often caused by defects in which of the following? Voltage-gated sodium, voltage-gated potassium, voltage-gated calcium, or non-ion channel membrane proteins.
Now send me to my long QT clinic this afternoon feeling really good. Oh, 86%. That's pretty good.
It's not bad.
So 2/3, 65 to 75% of all long QT syndrome, that is, turns out to be flavor 1 and flavor 2, are due to loss of function mutations in one of two voltage-gated potassium channels, either IKS or IKR. Second to last one, how did we do on the pattern recognition that will get asked on the board?
All right, so we've got an EKG. Which LQT type is it?
And nobody put number 5 just to play with me. Good. So what makes this for the board's LQT2? That does. So if you see hump, bump, notch out in the lateral precordial leads, that's LQT2 for the boards, and perhaps for your patient. And last one, this is the full everything.
16-year-old male, 12-lead ECG, and a history of near drowning. The most likely explanation involves...
And I did this one just so that you could have to read all of those
Yeah, that's
four.
nice.
Yeah,
Yeah.
so this was for you.
What they know is as long as I don't have to write it out, they'll be fine. So loss of function in the SCN5A, loss of function in the KCNQ1, loss of function in the KCNH2, or gain of function in the RYR2. Notice how I skipped it.
Yeah, you did good though. So great. So the majority have it. There's still room for Mayo's long QT syndrome clinic, which is always a good thing. So here, this one just to walk through, this is describing Brugada syndrome. This is describing LQT1, which you now link this near drowning as the swimming precipitant. This is LQT2, and this is CPVT. We did it. Nice job. Thanks a lot for having me.
Thanks, Mike. Excellent job.